Hello everyone, this is Karen Scott from TrueCode and welcome today to our presentation on getting ready for ICD-10, talking about some post-implementation strategies and things to do. We are just a couple of months away now from ICD-10, and so we're real excited to be able to talk to y'all today about ICD-10. Just a little bit of housekeeping things today to think about. If you do want to ask questions because you are in a listen-only mode, there should be a little feature that is going to say questions, little plus sign says questions over on your control panel, and you can just click on that under questions, and just we do have someone standing by that will take the questions. If we have time during the presentation, we'll try to answer as many of those as possible. If we run out of time, we will try to get back with you within the next couple of days to be able to answer your questions. So I think there's so much out there about ICD-10 and we really don't know, so we're trying to think of what are some of those areas in our research as we're getting ready for ICD-10. So let's go ahead and get started. So here's our objectives for today. And those objectives are just to talk to you a little bit about the latest issues, a couple of things that have happened recently with ICD-10 and our implementation. We want to then talk about documentation improvement, and then finally we'll talk about what to do once we get through October 1st. What about some of those post-implementation and things to deal with? And so tried to put in a lot of information in here today to help you going forward. So let's talk about some of the latest issues. Well, first off, we know that the final rule, actually the long version of the final rule came out, but it will be published in a easier to read manner on August the 17th, I believe is the date that it will be published in the Federal Register. So that is coming up on Monday. So if you haven't started reading the long version, and it is over 2,000 pages, so I've been kind of looking a little bit, but I hadn't really gotten into it all yet. But basically, this is the final rule. This talks about all the things that are going to change with the October the 1st date. So no turning back now. So I guess there's always that slim possibility that somebody in Congress might decide to put it in some other weird kind of bill. But we've really stopped hearing as much about people stopping it or delaying it. They're really more worried about, is everybody going to be ready? And what can we do to not penalize our physicians? So that's where you may have heard a couple of weeks ago that Medicare did publish saying that they would basically give a grace period to physicians about not penalizing them. Now remember, for physicians, they're still getting paid based on CPT codes, and our hospital outpatients, that's not changing. CPT is still that main procedure. That's how we're still getting paid for APCs and for physician professional fees. So really, physicians should not see a change in reimbursement unless there is a medical necessity policy. And if there is, where it says, here's the, for this procedure, we'll pay for that procedure. If they have one of these 5 diagnoses, that's where there might be a payment issue, to where because there are more specific codes in ICD-10, they may not know to get to those higher level of detail, and they could be penalized if a medical necessity plan or policy did not include the less specific codes. So Medicare basically said that as long as they can get into the right code family, like the first main 3 character category somewhere in there, as long as they get to that, then they won't have any kind of penalty there. But remember, this is only for Medicare. This is not for all insurance companies, and so we really don't know. And I really, as I'm talking to my doctors about this, as we're doing training, really talking to them about, you're not just coding for reimbursement. I know that's the big deal right now, but remember, they're using this information for medical necessity, for looking at the PQRS, the Physician's Quality Review Study, quality issues, reimbursement. Everything that they're documenting and coding now actually is going to be used probably about 2 years from now to be able to drive new things. And so it's really to their best benefit if they won't really go with this, they'll actually just go ahead, and if you know the more specific information, go ahead and document it so we can code it. It's going to be better in the long run. And so really, that shouldn't be anything different from what we're doing with ICD-9, but I know, again, we kind of get in that mode of, is this going to impact my reimbursement today? And if not, then we deal with that. The other thing I want to remind you of is there are some converting tools out there, the GEMS equivalent, the the general equivalence mapping tools in converting data. If you know what the ICD-9 code is, you can see what the ICD-10 code is. You want to be very careful with those. Those are only tools and should not be used as the fix-all thing that people are using so they don't have to learn coding. And I have seen this happen more with the physicians lately, and again, I know hospitals have developed these. There actually are different GEMS mapping. Different companies have their own, different hospitals have developed their own. So basically, it's a tool only. It's not always going to get you exactly to the right seat in the right exact code. It may get you to a general area, but maybe not to the right actual code. So I would be real careful with these because there's not a one-to-one. It's not like a crosswalk. It's more of a general equivalence. It might be any one code in ICD-9, maybe 50 codes in ICD-10. So again, there's a lot of things there. And here it just tells you a little bit more about that really may not represent the complexity of that patient's condition, and it could result in underpayments, but also it may overstate the complexity of the illness that could result in audits and retrospective recovery of payments as well. So you want to be very careful. And this just shows you about not one-to-one, that there's usually more codes. Now, sometimes we have fewer codes in ICD-10 because we have combination codes. So again, I just want to be real careful with that. So let's switch gears a little bit. And let's talk about documentation, on clinical documentation. So again, I think at this point, a lot of people have been trained. Our coders in all of our areas have been trained in ICD-10. Hopefully you're doing some dual coding. You're trying to make sure that you're ready and as comfortable as possible with these codes before we actually get to that deadline date of October 1st. Please remember that is the date of discharges or dates of service on or after October 1st. Also remember, if you have, like within your facility, if you're a hospital person, within your facility, if you have like observation bed, remember that Medicare has put out some information about if you have patients that are in for 2 days over that time period, they come into observation on September 30th, they go home on October 1st. You may have to send in 2 bills. There are basically 2 bills with the first date. If they have procedures done on the September 30th, that would be sent in with ICD-9 codes, and if they have different procedures on the 1st, that has to be sent in with ICD-10 diagnosis codes. So that's called straddled codes or split bills, and so there's not a rule about that, but there is one of those med learning articles on CMS's website for that. So that's what we want to look at as well. So we're still going to be using ICD-9 for a while because of capturing old data, any kind of old audits, RAC issues, those kinds of things. Now remember that we are going from a fewer number of codes to a big number of codes. I don't really like to talk about the numbers. We do that sometimes, but that scares people. Remember, you're still only using the code that you need at that moment in time and not worrying about the rest of them. There's codes out there that you may never use, especially in a specialty hospital or small hospital or a specialty clinic. So don't worry about the number of codes. Only look and see, and right now, what am I looking for? I'm looking for hypertension. What am I going to code there? What is the most specific information I know about that hypertension or that fracture or whatever that diagnosis or procedure may be? Remember, a lot of the new codes are simply because of the laterality, because when you have one for left and one for right, you have to have one for I don't know. And also because a lot of the injury codes do have the 7th character between initial versus subsequent encounter and sequela. So really, that's taken about half of the number of new codes are accounted for by the fact that we have all of these new codes for laterality and the encounters. Remember, that's not new information. That's not new documentation. Typically, the doctors are already staying left and right. We just hadn't been able to do anything with that. So some of the things, though, we want to let them know about are things like laterality, things like stages of healing, weeks in pregnancy or the trimester of pregnancy, episodes of care, those kinds of things, maybe new terms that we hadn't really talked to our doctors about. We want to make sure that we do let them know. And again, when we have incomplete physician documentation, does impact coding. One of the things that I've been trying to clarify with my physicians is that you need to understand that even though you're still being paid based on CPT, here's here's what's going on with the hospital, because they don't always understand why they're getting queries from the hospital. And when you're getting paid based on a different payment system than they are, they don't always see the translation and why you need this extra information. And so I've been trying to let them know that as well. If they're admitting patients to the hospital, you may be asking them more questions because your procedure system is different than theirs is. So we need to let them know those kinds of things. They sometimes don't get that. Also, remember with documentation, everybody needs to be familiar with the official coding guidelines. It is required by the HIPAA law. It outlines what we call the do's and the don'ts. A lot of them are very much the same as ICD-9, but some are different. Anyone who's coding with paper formats, whether they're coding from, I have a lot of physicians that are coding directly from their electronic health record, and they're not going to see, they don't always know we have all these official coding guidelines. So we need to make sure that we're aware of that. So if you're using a paper code book, those are typically found at the very front of the book. And also TrueCode has them in the research pane, and more specifically in the coding advice. And so that makes it a real easy way for you to find that using TrueCode as your coding tool. I also put in the link here if you want to go out to the CDC or the National Center for Health Statistics to their website. You can get to that exactly from this link. Now this screen just shows you a picture of what this looks like in TrueCode. And I just did a couple of simple things here. This is not a very big thing. I didn't want to have too much on this slide, but I just wanted you to show you the way that TrueCode works within the encounter. When you have ICD diagnosis codes, when you're highlighted on a code, all your references are over here. So you can see for this code I'm highlighted, the I-25.729, it has all the official coding guidelines. And then what we do also is we put, especially for ICD-10, we have started putting all of the guidelines out here as well under coding advice. That allows us to really showcase, and you can really see it. You don't have to open anything up. It's right there. And remember, all these references are attached to the codes themselves, and so when you click on them, they change. And so that's going to be a really great tool to help you and increase your productivity, because you're not searching or having to go, what was that rule about, this particular thing, or what do I do if I don't know if it's a displaced or a non-displaced fracture, or how do I find that out? Oh, it's in the coding guidelines. Oh, I need to go check it. It's all right there for you. So that really does help with your transition. The other one you want to really remember about is Coding Clinic. Remember that Coding Clinic has been around since the 1980s, and Coding Clinic has transitioned over to ICD-10. This is just a paper copy of what this might look like, but basically we want to make sure that we're following this coding advice. And I've been really watching these Coding Clinic articles lately because, especially with ICD-10 PCS, we're desperate for information, for guidance on how we should use this brand new coding system. And so again, you've got the Coding Clinic articles right there. When you open up a code in ICD-10, the Coding Clinic articles are there. I noticed the other day, because we had the second quarter Coding Clinic articles came out July 1st, and we got that in our update that went out on July 9th. And the first thing I do when I get those is I look at them and I see if there's any correction or clarification. There was one case where I had been teaching people on how to code the portacaths based on what they told us in the Coding Clinic article back in 2013, and they changed their mind. Now I've got to go back and retrain everybody. So I keep telling people, it can change, so make sure you're keeping up with that, because they do give us a lot of information. But also remember, with TrueCode, you also have your edits, and I just opened up the edits here, and whenever you see the little yellow triangle, it tells you, use an additional code to identify. And also here's one that says use an additional code if they get the TPA in a different facility. So utilize your different references and your edits, all of those right there on the screen with you, to make sure that you've got everything you need and you don't have to look anywhere else and waste your time doing that. It's all right here for you, and it makes you feel comfortable, because there's no way to remember all those rules. And so is there anything different? You'll see it right there on the screen as you're actually doing the coding. So I think that can really be helpful as well. Now, let's talk a little bit more about documentation and get more detail about that. What we want to do is use ICD-10 actually to set as basically a new standard for clinical documentation. You really want to focus in on the fact that documentation, or that the ICD system is a clinical system based on clinical information about how medicine is performed today, not in the 70s. It was designed by the World Health Organization. We keep focusing on that it really does make better sense to capture what's going on here. So we want to incorporate that into our electronic systems as much as possible. And also, if you can compile any sample coded charts. I know a couple of my clients have got their major procedures when they've done their top 10. They have coded some of their harder procedures and copied them and put them into a notebook. And then they've got the codes next to them and it's all referenced. And that way, if the coder is working on one, and if she has questions, she can just go to that book and look up, okay, how do I code a transfusion, or how do I code, whatever it might be. They've got all the samples in that notebook. So I think that might be a really helpful tool to get them ready. We do know we want to kind of focus in on risk. What are your high-risk codes? You already know what your main diagnoses are, your main procedures. What are the ones that you already know are problematic as far as documentation issues there? Remember using those to justify our medical necessity. Remember, all of these are going to play into coding accuracy and coding productivity. And as I mentioned earlier, future financial impacts, typically 2 years from wherever we're looking, that information, it's all going in the big database in the sky, and it's all going to be used to change reimbursement. It may have a big impact on our DRG system for hospitals, and we definitely know it's going to have an impact on quality issues and also outcome, information about outcome that we really are looking for now, and so that these codes can really show why the patient is being treated with the types of treatment they're getting at the level of service or place of service that we're getting there. Okay. Remember, again, if your doctors are going, oh yeah, I don't have to really worry about those codes right now, again, then your billing and coding might be at risk 2 years from now, and they aren't always thinking about that. So you might want to talk about that as well. The other thing that I really think we need to really focus in on getting ready is the electronic health record. We thought that it was going to really help everything. It was going to be the end all of everything, but the systems are not always great. I have some doctors that are on medical staff at 3 different hospitals, and they have 3 different electronic health records, and they don't have time to learn it all well, and so they're using the check boxes, and they're not actually documenting anything outside of that. I've had doctors tell me that I don't have time, it's too cumbersome, it doesn't work right, it fails all the time, there are all kinds of problems. And so this is just one of the quotes that really I think helps tell the story. It says basically the doctors are not doing that. We've lost that 100-year-old tradition of the narrative that tells the story in a manner that's easy to understand and remember. Even our long-term physicians have abandoned the clinical narrative and simply click a line or 2 in the EMR. So instead of having better documentation, we're actually getting less documentation. And I was working with a group of nephrologists yesterday, and they were talking about the fact that, they think that they should be able to go in their electronic health record and find all the codes, and he said he spent 45 minutes looking for a code, and it wasn't in there. And someone from their facility said, oh, it doesn't have all the codes, it's got your most commonly used codes. He didn't know that. He had spent all of his time looking for a code description because we had told him to be searching for or give us the most appropriate documentation, most specific as possible, and he couldn't find it because it wasn't in his system. Many times they think that that code list is total, it's the whole entire book, and it usually is not if it's within their EHR. Now there are some EHRs now that are actually putting TrueCode as a component, and so that kind of helps, but that's, again, that's something that could be happening in your areas. This is what an effective EMR documentation should do. It should improve patient care and quality and outcomes by doing all the things listed here. But instead, we're seeing people cut and paste. Cutting and pasting is actually not as helpful as many of them think that it is. We don't need them to cut and paste lab and x-ray. We can see those. We can tab over and find those. They also sometimes cut and paste when they are going from just trying to show what another doctor did and copy it into their documentation. Sometimes that means dual two billing or over billing because we think that that second doctor actually did that procedure. So those are the kind of things that does get bad information can get repeated over and over. We actually had a case not long ago with an ER physician, and he was looking around on the internet, and his kids had sent him some kind of, looking at happy kitties at Christmas or something, one of those silly videos, and he'd been looking at it, and somehow he clicked on it, and then when he went to work on the patient's record, he accidentally pasted it into that patient's record. And so then they had this video of kittens in the patient's legal medical record. And again, that happens all the time. Or the doctor that was on call, and he, they told him, oh, the x-ray's ready. So he opened up the x-ray for Mr. Jones and looked at it and clicked on it. And then he went back to Mr. Smith's chart and accidentally clicked and pasted it into the wrong patient's record. That happens all the time. So we're trying to make sure that we're cutting down on the cutting and pasting, because it really doesn't do as much good as they might think it is. So what we really think we should focus on is that the doctors don't really need to be taught ICD-10 codes per se. They do need to be taught concepts of documentation, especially in the electronic medical record, and they need refresher courses, little bits and bites of what to do, because they forget it. I'll have a room full of physicians, and one of them will say, I can't do that in my EHR, and another one will say, oh yes, you can do this. So they don't always remember everything, and so this is a good time to kind of do some little mini tips for your physicians on what they can and can't do in the electronic record. So we want to talk about advantages of increased specificity, again, not just to get paid appropriately, which is very important, but also looking at severity, risk of mortality, better reflection of the quality of care, better tracking of outcomes, and that should all in turn go into improved payments over the years based on severity and or quality, and better quality in research and clinical trials, but only if documentation is sufficient to take advantage of that increased specificity. So I want to address this, and I usually do this in almost all my presentations lately, because I think this is critical right now. If you haven't done this, I've still got a lot of people, because they're busy, and I know we've got so much other stuff going on, they haven't done their gap analysis yet. And so I want to make sure everybody understands that, and that if you haven't done that, this is a crucial time to be doing this. Typically a gap analysis is this. Look at what you've got now in your current documentation, and then use that same documentation to code using ICD-10 and see what the gap is between the documentation we have and the documentation we need. That's the gap. That's how you analyze the gap from what we have to what we're going to need for ICD-10. That is the only way you can start addressing key areas specific to you in your clinic or your facility. And so that is typically an easy way to do that is your top 10. Not based on reimbursement, but your top 10 DRGs. For hospitals, top 10 medical DRGs, top 10 surgical DRGs. In the outpatient, top 10 outpatient or ED diagnoses or surgeries, whatever that might be. From clinics or professional fee services, your top 10 reason for visits or your top 10 diagnosis. Typically, you're going to look at about 10 charts out of each of those. That may be 100 to 200 charts. Again, you're just doing a snapshot. You're just looking at documentation needed to code this case. And then you can figure out what is it we're missing. You might find that in 8 out of the 10 diagnoses, you're perfectly fine. Remember that a lot of the documentation that we need, it's more than what we needed in the past, but a lot of it is not new. It's not extra. It's already there. You know, when they're coding lefts and right, or they're telling us lefts and rights, right now I can't do anything with that, but in ICD-10 I can. So that's another really good point to keep remembering, is that just because we need to we have more doesn't mean it's not documented, okay, because it's really already there in many occasions. So we want to compare the documentation. We want to provide feedback and education to all the different areas, including the physicians. I had a doctor yesterday say, is somebody auditing this? And they said yes. And they said, do I find out about this? And they said, well, do you want to? The doctor said, yes, we want to know if we're doing it right, if we're doing it wrong. We need to know those things. So please, sometimes I think we don't involve the doctors because they're busy, and we don't know that if they want to know about it, but most of the time they do. They want to know how they're doing, and if they can help you, give them that feedback on what you need from them. They usually like that. Now, these are just some of the areas of concern in diagnosis coding. We are not going to go through all of these because of our time frame today, but I just wanted to tell you that lots of times when we'll do these kinds of webinars, we'll go through and show you different examples because these are things that are different. And let me just stop here and give you an example there. When I'm talking to my physicians, again, and this is true whether you're in a hospital or a clinic's office, because documentation is the key to so much of that. You can have the best trained coders in the world, but if you don't have the documentation to support it, or you don't have the backing from administration to be able to get the documentation that you need, that is going to prove to be a huge impact on your reimbursement, on your bottom line, your dollars going in and out of your door come October 1st. Very, very important that we have the doctors on board with this. So one of the things I talk to them about is like asthma. I can code asthma in ICD-9, I can code it in ICD-10, but the code for asthma is just a generic, it is a chronic condition. It says basically that this patient has this chronic condition, it's under control, they may be on medication for it, but they're not having a big deal with it today. But if that person's coming to observation, or they're coming to the ER, or we put them in the hospital, that's probably not plain old asthma. Yes, there's a code for that. If you just say asthma, I can code it. But does that justify why they're in the ER? Why are they here? Because this is a chronic condition, and it's because they have an acute attack of it today. Tell us that. If you'll tell me an acute attack or an acute exacerbation, that changes my code assignment. That shows me a more level of severity, and it justifies why the patient is being treated there that day, as opposed to in the office or at home. You know, why are they being admitted to the hospital? Well, because the normal medications that we give them don't work. Is that status asthmaticus? Because that's the definition of it. Yes, it is status asthmaticus. Great. Tell us that, and we can code it, and that will showcase, and it'll justify your procedures, your decisions. If you have an infection and you know the bacteria that's causing it, it probably won't get you paid more, but it's going to justify why you had to use that more expensive antibiotic, because now you're telling me it's methicillin resistant, and so that's a big deal. So those kinds of things may not give me an extra dollar today, but they paint the picture. They show this is a more critically ill or clinically more severely ill or injured patient, and they build my picture. They help us justify procedures or office visits higher level. So there's all kinds of things that the right level of code can do for us, both from the hospitals and the physician side. Okay, so that's what you want to look at when you're talking to them about their documentation and looking at all of those kinds of things. I do want to take a minute to go through you quickly with my standard example of looking up codes and going from an ICD-9 to an ICD-10. And what I did is I just pulled out the fracture information. When I look up a code in ICD-9, the first thing it tells me is it is an open or a closed fracture. And in ICD-9, it gives me this big long list. And so basically it says a comminuted fracture is closed. If they say in the x-ray that it's a fissured or a green stick or an impacted, all those different terms, because of the limitations of ICD-9, all of those terms tell me that all I can do with that is group it into closed. So basically what we've had to do in the past is, even though the x-rays and the doctor's documentation, the operative reports, tell me specifically the type of fracture it is, this is a comminuted fracture, basically it doesn't show me any different, because all I can code that is open or closed. So if you think about the outcomes, someone who has a comminuted fracture that is splinted or crushed, that's probably not going to grow back on its own. That particular diagnosis is going to need probably an open surgery, a pin, a plate, something to help the bone grow back again. But a green stick fracture, which is partially broken and partially bent, that one is probably going to need to be, you know, put back in place, casted, strapped, whatever, immobilized, and then they're going to be fine. It'll grow back just fine. But right now with ICD-9, I can't show the difference there. I can't show the level of severity for these two different patients. And it's very different clinically, but because of the limitations of the system, I can't do anything with it. And then here's the list for open in ICD-9. Here's some choices there, and that's all I can do. So you can see here with like acetabulum, it's either closed or open, and that's it. I don't have any other information. Or even if I do have other information, I can't do anything with it. When I look up that same thing in ICD-10 and I go to fracture traumatic, first off, we have two different categories, pathologic versus traumatic. The traumatic one, there's lots of choices. Under acetabulum, I have lots of choices. So now I can look at that x-ray report, I can look at that doctor's operative report, and I can pull out, and he can give me the most specific information about it, and now I can do something with it. I can code it, you know, based on this level of detail. So that's really exciting to be able to see this type of information. All right, I do know that each fracture is going to have their own area. So like the comminuted fracture, this S72.35 has its own category there. And within it, it has 6 choices. Is it displaced, meaning the bone is out of its normal location, or is it non-displaced? And is it of the right, left, or unspecified? And also don't forget, you have all those official coding guidelines that we have to remember, or at least have access to, that are right there. This is again a picture of a true code where you can see it tells me if a fracture is not indicated, whether displaced or non-displaced or displaced, should be coded to displaced. So that's my default code there. So I have those set up for me so I can make sure I'm picking out the right one if my doctor doesn't tell me. And that also means I don't have to go back and query them because there's a rule in the official guidelines that addresses that. So then I also see that there's a 7th character. Now in my code book it shows me the plus signs. In yours it might be like a check 7th or something like that, but it's a good visual tool to help me know. And then I go to the 7th character, and then I have to pick out if it's an initial or a subsequent. If it's subsequent, if they're coming back, why did they come back? Routine healing, delayed healing, non-union or malunion. And then is it an open fracture type 1, 2, or 3? And that's the Gestell classification. You can look that up and see what that classification is. And basically it has to do with the size of the wound that's along with the fracture and whether it's a clean or a dirty wound. So all that information we have to capture. Typically in an audit, when we do a gap analysis, we can make it all the way to here before we find, oh, I don't have this information. Usually everything else is already documented, left versus right. We know what to do with displaced or not displaced. But here I have to know if it's open, what the typing is. So where do I get that information? This is what a gap analysis does. It allows you to go and say, here is a problem. What can I do to fix it? Where are we going to do this? Are we going to put it as a drop-down box or EHR? Are we going to make it in a template for my doctors? Are we just going to do a lot of education and, you know, ask them questions all the time? How do I get this information that we need, that we haven't needed in the past, into the medical record? That's what a gap analysis will do. So that was just a quick overview. Hopefully a lot of you have already done that before, but that's what you need to be doing if you haven't done it already. And I can't tell you the number of times lately that I'm hearing people, you know, I'm asking these questions in classes, and very few of them have done their gap analysis. The other thing you want to talk about with documentation is that ICD-10 CM, because it is more specific, it can help tell the whole story. And that's really always what we're doing with documentation. We're trying to tell the whole story. So you can see this patient was admitted with congestive heart failure due to hypertension disease. They also have stage 5 chronic kidney disease, and the patient is on Lasix but frequently forgot to take their meds due to his age. In ICD-9 and ICD-10, I can code the first 3 things: the hypertensive heart, chronic kidney disease, the failure for the heart failure, and the chronic kidney disease stage 5. What I can't code in ICD-9 that I can code in ICD-10 is, as Paul Harvey used to say, the rest of the story. I can show, hey, why has this guy been in the hospital 5 times this year because he's for congestive heart failure? That doesn't make sense. Is the hospital sending him home too early? Is the doctor not doing their job correctly? Well, now we have this new term that's called underdosing, and we can code it and say this person is not getting the full effect because they're underdosing. They're not taking enough of their medication. I can add an additional code that says the reason why. Patient's unintentional underdosing of meds due to age-related debility. Now, I'm not only telling the medical conditions, I'm also talking about what else is going on. So now if we need to prescribe home health, or we need maybe to talk to the family about an assisted living facility, this gives me justification. I'm telling the whole story about the patient. Very, very important. A little bit more about documentation, and then we'll move on to the strategies and things that we're looking at for the future. And again, remember your documentation, the severity. We've talked about all of these different things in the past of why we need to move forward with this and what we need to look at as well. We do know, again, this is something to share with your doctors because it is important for the hospitals. You know, what kind, if you have CHF as a secondary diagnosis, if it's just CHF, that doesn't help us. It doesn't show the severity or the complexity or why this patient needs to stay in the hospital longer. If you'll give me specific information, if you know it, then this makes a difference. And again, we're not treating the patient any differently. You can see this person actually stayed in the hospital for 9 days, but the documentation basically is going to be your major bowel procedure without an MCC or a CC. But again, if he gave me more specific information, if it was appropriate, if it's chronic diastolic, that's going to group to a higher weighted DRG. And basically, if it's acute on chronic, if it is that, then it's going to group even higher. higher, and it's going to be able to reflect more appropriately the level of resources needed to be able to take care of this patient. Here's another severity example, COPD, exacerbation with acute bronchitis. We also saw that Stultz were occult blood positive, and the EGD confirmed gastritis. If we only code it like that with the principal diagnosis of COPD, with the secondary diagnosis of gastritis, again, that's going to put us into the lowest weighted DRG for that grouping. However, if we did a query and we went in and he did say, yes, that patient did have a GI bleed, that takes us to a higher level. If they put that due to, that's another thing we're trying to teach our doctors, tell us due to, because now that it's linked, that puts it at an MCC and gives us the higher weighted. Again, remember, we've already taken care of this patient. We've already had them in for however long is appropriate, but if we can get the level of detail there, if it is appropriate, then we can go with a more appropriate reimbursement there as well. So some of the things that we'll have to deal with, reflection of severity, these are some of the listings here, and I'm not going to read all of these. Again, if you want to get a copy of this presentation, we'll be sending that out after the presentation today. But this is nothing new. This is just what we've been looking at in ICD-9 and we'll also in ICD-10. These are some other things. Again, urosepsis is not even a term in ICD-10, and again, you need to look at some of the different official coding guidelines on how those are coded. Things that we're going to need more specific information in ICD-10, respiratory failure, if it is with hypoxia or hypercapnia, asthma, we need the severity level, whether it's mild to moderate, intermittent or persistent, the heart attack, if we did a cardiac cath or cabbage, if we know the coronary artery involved, that gives us a more specific code. The strokes or CVAs, again, when we do the roto-rooter procedures, we need to know the specific artery involved, injury, specific site and laterality, and those open fractures with the Castillo open fracture scale. So those are some things that are new. You can see here, again, documentation or lack of makes a difference for the hospital's professional or the hospital's appropriate reimbursement there. So the terminology does definitely make a difference, besides if you just say malnutrition or if you give me more information about the malnutrition. Okay, so we already talked about doing this self-assessment, talking about your top coded diagnoses, review the specialty codes for cause and effect, manifestation, review your current clinical documentation, and make friendly, helpful recommendations. I like that one. Create your own crosswalk for your most frequently coded items and share that information, and also cross-training and knowledge training as well. Little things that doctors can do for us, right versus left. I know that seems like a little thing, but if they're not doing that already, that would be tremendously helpful. Documenting all manifestations and complications due to, and also be clear on past medical history diagnoses as opposed to ongoing chronic conditions. Okay, so now let's talk about it from the perspective of post-implementation. This is all kind of things you should have been doing now, things you should be doing in the next couple of months, and these are some of the issues. So we know that some of the things, for example, reporting requirements may increase. Anytime we put in a new system, like when APCs came out to the hospital back in the 2000s, we know that changed some of our reporting. They were asking for more things. We know that the technology and systems, if they haven't been upgraded or replaced, that may be something that you're working on right now. We're seeing a lot of new value-based purchasing initiatives, trying to make sure we're ready for those as well. And also remember about your budgets for investment in a good electronic health record. I have some areas that are just now trying to put in an electronic health record, and they're going to have a crazy next couple of months. We know, again, your clinical documentation. You need to know what that documentation is to be able, and what you need from them to be able to support that. And also just keeping our coders. I'm starting to talk to people where they've already trained all their coders, and then the coders are getting a better offer and they're leaving, and they already paid for their training. They've already paid and put all that money into training them, and now they're leaving. What kind of incentives do you have in place that you can do that can keep those experienced coders? Because we need them. We desperately need them. For people to be losing coders 2 months out, that's pretty scary. So, talk to people. I know you can't always pay them more, but what can we do to make them happy here and providing a good training for them to go there. We also want to address any kind of processing errors that can cause claim denials or reduce cash flows. as you are talking to your doctors, again, making sure there's just a couple of slides in here about why they should learn ICD-10. We know with direction for healthcare reform, we're seeing increased use of bundled payments in the state of Tennessee, where I live. The state of Tennessee and the state of Arkansas, they're already doing these episodes of care with Medicaid, and that's things that are going to increase in the future. Moving more from the reimbursement driven by volume to value driven, and looking at like episodes of care and capitation. We're seeing those as well. So there's a lot of things going on, a lot of different ways that we're going to get paid in the past or in the future that are very different from how we got paid in the past. So again, I just put in some examples here so that you would have that if you need that to kind of start talking about how this is going to work in the future. And the episodes of care can translate into bundled care payment. And this example right here just talks about the fact that when you have this patient coming in, they break their hip, they have a hip prosthesis. Right now there's bills coming from all different directions, all paid separately. They go see the doctor, they go to the hospital, they go to the rehab. In the episodes of care with the bundled payments, that can be where one payment is going to be received, and it's going to be given to one entity, and that entity is responsible for all of that, whether it is rehab or if they have a complication or anything like that. It's all part of that same thing. It's kind of like the DRG system is for inpatients, but this is going to cover inpatient, outpatient, post-acute care, all of that into one, and it's supposed to make sure that we've got more continuity of care. And we're seeing a lot of interest in this kind of methodology, and again, these codes are huge for these. So have you done your baseline measurements? Do you know where we are now? What is your coding efficiency? What is your coding productivity? What about your queries, your current queries? Look at those high volume or high value clinical areas and go ahead and see what do we need to do to convert those over for ICD-10. Are they going to be the same? Are the codes going to be the same? We need to go ahead and get those in place now. And also looking at your DNFB or your not billed, not final billed, or your unbilled list, or your days in AR, whatever you call it, however you measure the cases that are not able to be billed yet. Want to make sure that we're looking at those, looking at their current impact and potential impact over once we make that transition over. I've talked a lot about doctors today, but remember, you've got doctors within your network. Even if you don't own a clinic or your hospital doesn't code for clinics, you've got those doctors in your system. We have the, a lot of our physician offices don't employ certified coders, and in fact, I've got a lot of physicians now that they say, I talk about them working with their coders, and they don't even have coders. So the doctors are either trying to do it all themselves, or someone that have not been trained very well might be doing this too. You've got doctors sending patients over to your hospital. So how are you addressing that? What are you getting from them? Are they sending codes over? Are they sending diagnoses? How specific is it? Is it specific enough to justify when you're trying to get paid for medical necessity? We all have to work together. And so even though, again, they may be training separately or hopefully training at all, you want to make sure, because that can have an impact in your hospital network as well. You should have already been checking with your vendors for their readiness, all these different things. Again, I'm still got people that are looking at different things and trying to get things in place. One good thing about TrueCode is it doesn't take long to put it in. Once we get the contract, basically it can happen very, very quickly. So that's a great, looking at the tools. It's not too late to do that, but I would do that pretty quickly too. What about updates to your system? And also I'm starting to see, I was talking to a client the other day, and their IT department said, we're going dark for the whole month of August because we can't take on anything else. Don't call us. We're just going to work on the things we have. They have, basically one emergency type person, and everything else is shut down. It's not shut down. They're working, but they're not taking on any new projects. So that's kind of scary. So you want to check with that. So if you're waiting to the last minute to find some things out, you might find that you're going to be in a queue for 6 months. So you want to make sure that someone in your facilities is taking care of those kinds of things. Okay, we've talked a lot about these things, your vendors, your partners, how are they getting trained? How are your outsourced companies getting trained as well? Okay, so implementation, post-implementation review. Again, I think I've talked a lot about that as we've gone today, but I wanted to make sure we're going to kind of highlight in on, what are some of those things you really want to be focusing on. We don't know all the impact, but here's some things that we think that we should kind of minimize. One of the big things is minimizing productivity decrease, and I'll give you some more information on that at the very end today, which is in about 15 minutes, so we're rocking and rolling right along here today. So one of the first steps we need to do is making sure we're looking at our payers' contracts. We are seeing some of them are paying based on DRGs, some of them are using older versions of the DRGs, some of them have payment formulas, some pay, there's basically like code numbers, like we've been working in the state of Tennessee with the workman's comp, and their policies are basically on like the trauma codes. Here's the range of trauma codes, we'll pay for those. So they're paid based on code numbers. So look at your contracts. Are they putting ICD-10 in the contracts? Is your contract with them 10 years old and they're just automatically renewable, and unless someone says about it, you just keep getting it over and over, and they haven't actually changed those? They may still have ICD-9 codes in there, and you need to have those payer agreement negotiation discussions with those. What are your backup plans? We want to have those in place now. A lot of the good coding companies are already booked up, and they have some people, they're on kind of like contingency plans if we need you. So again, we don't want to wait to the last minute and try to find somebody. You may not be able to find them. We want to make sure we're streamlining your workflow. This is something that I think is hugely important. Look at your process from the time that the patient calls in or shows up to your emergency department to the time that that bill is paid. What does your workflow look like? Map it out. Do a flow chart of exactly what happens. Anywhere that you're missing information, or you're waiting on someone, or there's a backlog or a bottleneck in the work, that needs to be addressed now, because if it's bad now, when everybody's slower in the future, that's going to just magnify that probably 10 times, if not more. So work on your workflow now. Again, I know you're very busy, but that's a really key area. Even if you're a 3-person doctor's office or a 500-bed hospital, whatever, you want to make sure that your workflow makes sense and that it's all working appropriately, because that's going to make you less frustrated, and that's true even if we never went to ICD-10. And then we talked about the gap analysis. So those are things that, again, might need to be taken care of now that are essential here. What you want to consider for post-implementation is, what about your denial increases? Now, I see lots of different things on this, and I try not to put, too many kind of facts and figures, because these can change and people don't know. But, we're saying denial rates may rise. If you've got medical necessity issues, that can be a denial rate. We may have the computer system. There may be glitches in the computer system. And so that happened with APCs when we transitioned over, is that sometimes the computer systems, it wasn't flowing appropriately. I had one facility that was not getting paid appropriately for chemotherapy because their system had a glitch in it, and the actual code for the medication, which is the most expensive part of chemotherapy, wasn't going over to the bill. And by the time they realized what was going on, some of the claims were too old and they couldn't go back and get that money back again because they were busy. There's so much going on, it's hard to stop. But you got to make sure that you're checking for those. What about your days in AR or your DNFB or your unbilled accounts? If we are slower, that's going to increase. Then what's going to happen? I've talked to people that have said, well, we're going to keep our DNFB or our days. We're saying, okay, right now we should have, from the time a patient is discharged to the time the bill goes out, we're keeping it at 4 days. Is that realistic? I don't know that it is in every case, because again, you're not just talking about the coders being more productive. You're also talking about documentation. And if they're not getting that documentation, and if they're going to have to go back and query doctors and then wait a week for queries to come back, that's going to mess up your dates. So that is, I don't know how realistic it is to say we're going to be able to keep it just exactly the same. We don't know that. What's your backup plans just in case? Okay, claims errors. Again, we don't know, but we have heard people predict that those could be more than 2 times higher with ICD-10. And so again, is that from our side? Are we submitting bills with claim errors on them that have to be kicked back, or is that from the insurance company side? I was at a meeting 2 weeks ago with a lot of big insurance companies, and they were telling us that they're ready. The big guys, they're ready to go. They've been checking, they've been training, they've got our medical necessity policies ready to go. Some of the smaller areas may not be as ready, so that's the kind of thing you want to be checking on as well. What about your backlogs? Again, we think that that could be an increase because of waiting on documentation. What is that going to do to your cash flow? How are you making sure that you are ready for it? What is your contingency plan? What is your backup plan? And I'm not saying this stuff to make you scared or to want you to, get out of this profession. I just want you to be thinking about what is our backup plan and be realistic with administration, because it could possibly go really well, but they need to know there's a potential that there may be some issues, and we got to have a backup plan, and we need to have our expectations clear ahead of time there. Your release of information, you may see that there are more chart reviews due to greater chances of misinterpretation. You might see with medical necessity, because that's going to be based on the more specific codes. That may be an issue. And also you might see an increased potential for protected health information issues, security and privacy risk as well. Your processing issues as far as processing the bill, again, if you're a coding professional, you may not be on that side of it, but again, it's got to go all the way. And if you talk about, possibly doubling our number of days that it's going to take us to get paid, a clean claim, typically, if you send out a claim that's going electronically and there's no problems with it, that's called a clean claim. Typically, it can get paid in typically about 10 to 14 days. What if the insurance companies are not able to do that, and if it's doubles or triples? What is your contingency plan for those kinds of things? We just don't know what's going to happen. It was kind of like at Y2K. We really didn't know when the clock struck midnight in the year 2000. We didn't know what was going to happen. So all we can do is be as prepared as possible. Again, is trying to go through a lot of these things that are some post-implementation issues, poor understanding of the new code sets and coding requirements. We got to make sure we have that transition planning, and you also may need to run dual systems to facilitate adequate reimbursement and cash flow. You need to make sure you have the documentation there. We really think that denials are going to be more about specifics. Instead of just general, they're going to be real specific. Okay? Again, if you would have used a more specific code, but we didn't have the more specific documentation to warrant the specific code. So we need to make sure we're capturing the details, though. And we need to make sure those responses we're getting are from those with chart knowledge. So we've got HIM professionals, we've got nurses that are working as CDI or clinical documentation improvement, really working. That's probably got to be a focus right now, looking at those things, making sure we have documentation, specificity, medical necessity. So that's going to be a really key player in this transition is your CDI team. So the more you can teach them about coding and understanding what to look for, it's going to make it so much easier too. We need to have a way to communicate between the business office and the HIM department. What are our current denials? Where are they in the process of management? How effectively the codes are going to be managed when they've been changed? What happens when a code is changed or documentation is amended? What happens in our electronic system? Who is in charge of that? And like I mentioned earlier with our system review, looking at our process, looking for bottlenecks, poorly managed handoffs, or workflow issues. All of these things can help with your post-implementation. Also, post-implementation, you want to make sure you're tracking and trending denials. You want to set up a metrics to be able to help you better organize and identify post-ICD-10 denials. Looking at our trends now, what do we normally, are these medical necessity issues? Are these, whatever they may be, you want to have them, and that's what I mean by metrics. Give them a name. These fall under the category of medical necessity. These fall into the category of, not having the documentation, whatever it might be there. And categorize those reasons for denials and identify any payment barriers. What's keeping? We need to really be on target, especially the first month or two after ICD-10 takes effect. We've got to be really watching those denials, watching if those claims are actually being processed, because we're really concerned, especially with some of those smaller insurance companies. Are they even going to be able to accept our claims and then be able to pay us? We may be sending in the right information, but are they going to be ready to accept it and get us that payment back again? That's why testing right now with those insurance companies is very, very critical there. Also, you want to make sure that you're looking at your staff impact, looking at that implementation, looking at your impact on claims, and again, making sure that we have not only early education, but continuing education. So all this education we've been doing, you might find a different set of factors after. So we need to make sure we're doing audits, that we're looking to see what are our conditions, what are our ideas. We knew we were going to have problems here. here. And so we've addressed those, but then after the implementation, now what? There may be some things where we didn't even know were going to be a problem, and now they're a huge problem. So again, we got to keep that into place. The more you can plan for this now, the more you can have this plan in place and know we've got to do a lot of audits that first couple of months to make sure that we've got this correctly. Because again, if we get paid incorrectly, somebody's going to want that money back. We talked about the disconnect between physician language and coder language. Sometimes that happens, especially with ICD-10 PCS. You know, we know that the doctors are going to say one thing and the code book may call it something different, and we're going to have to be the interpreters for that, and making sure that we're really definitely understanding that level of detail in the root operation for those PCS procedures. Again, our CDI documentation review, very, very important, but we want to keep doing as much as we can pre-discharge, reviewing the documentation, review your query program. How's it working now? And maybe you need, if you've got some areas where it's not working, or we send queries out and we never hear back from certain doctors, again, that's where you want to get administration involved and say, you know, this is part of our queries should be just as important as not giving us documentation. You know, so what is your ramifications? What are your denial or your, you know, you're kicking them off medical staff, or whatever it is you do in your facility or in your clinics to put some teeth into it, because we have to have that and we have to keep them accountable for that information. Streamline your documentation workflow. I think I've said that about 5 times today, because I think that is so critical in making sure that we're ready to go. Where there's usually things we're frustrated with that aren't working well. Let's see what we can do. Let's sit down at a table together and try to figure out a better way to do it. And usually when that happens, when I facilitate those, basically people go, oh, you're doing that? Or, oh, you thought I was doing that? I thought you were doing that. Oh, I'll do that. Okay, that's much easier for me to do it at my level. You know, but we're kind of in silos. We may be really good at our one area, but we don't always know how things fit in together. And we're all on this team together, and we got to be ready together, and we got to work together, or we're all going to want to move to the beach and become bartenders in our next job, because healthcare is going to drive us to the funny farm or crazy farm or whatever it might be. So anyway, talk to each other, talk about our workflow, work as a team. Also look at your automated tools. You know, look for query software. Look at your encoders. You know, again, if anybody's still using paper charts or paper you know, using the paper code books, again, lots of good things out there, and at TrueCode would love to talk to you about that and show you how we can help you and assist you in getting ready for ICD-10. Electronic documentation, and also computer-assisted coding. For example, we're embedded in 6 of the leading computer-assisted coding products out there on the market. So it's embedded. It's not interface. It's actually part of it, and that's going to streamline your process when you've got one there. Instead of them having to have 3 different screens where they're going from here to there to somewhere else, it's all in one product. How cool is that in keeping us more productive and having to really be able to more effectively utilize the services and use our skills a little better there. We've talked a lot about reducing productivity and making sure we're looking at our knowledge base, making sure we're eliminating coding backlogs, using outsourced personnel if appropriate for those. And remember, productivity is not just going to be coding. It's not just the doctors. It's also anybody that's dealing with this during the initial implementation. Your case management, your clinical documentation team, your HIM, your claims processing, your electronic billing system, collection, decision support. Really, most departments in the hospital are going to be impacted by ICD-10, and we all got to look at our productivity and making sure that we have the tools in place to help with that. The other things you want to do in getting ready and even after is prioritizing those records to be coded. Again, keep your training going. You know, we're coming down to the wire here. How long has it been since they've been trained? What are some of those issues identified? Come back to your staff, come back to your doctors and talk about what we need there. What have you found out in your CDI? Some of my clients have started already turning on. They're already dual coding. So they're coding in ICD-10, so they're really getting comfortable. And that is so important in coding to make sure you're comfortable with the system. We don't have all these codes memorized like we did in ICD-9, and so we're going to be a little bit slower. We're not going to trust ourselves as much because it's new and it may take us a different route, especially with the PCS procedure coding for our hospital inpatient coders. We need to have a lot of backup and a lot that we can do to be comfortable with this new coding system. That may take us a little while, especially with PCS. Okay. So productivity and accuracy strategies as we're finishing up today. Again, identify what steps can be taken to diminish your effects of decreased productivity, review and determine the effect or impact of decreased coding accuracy, and develop a quality improvement plan as needed to get us going with that. All right, so here's some things. A lot of this we've talked about already today, preparing for the decreased productivity. That's probably one of our biggest areas and unknown areas that we have with ICD-10. I think we feel a little more comfortable with ICD-10 CM as we've been training on this. It's very similar to ICD-9, but we're more concerned, I think, at this point with the lack of documentation. Do we have that? Do you feel comfortable with it? Your doctors know what we need from them to be able to give us what we need to be able to code appropriately. And then lastly, just some implementation checks. Again, remember, you are going to be ready depending on these things, your amount and level of preparation, how much coding staff, education, and sometimes even their credentials, your code assignment experience, everybody's knowledge of anatomy and disease process, the extent of their training, the quality of the medical record documentation, and also your organizational size and complexity can make a big difference in your implementation and how easy and smoothly this is going to go for you. So here are just some last minute things, just as we've talked about, kind of to wrap it all up today. These are the things we've talked about today, doing now in the next 2 months. And then again, I've tried to kind of pull it all the way around full circle, talking about what we know now, talking about documentation, because we know that's such a critical issue in getting us ready, and thinking about not only what we need to do in the next 2 months, but what are some of those things we need to do in the future or right after we go forward with ICD-10, because it's going to be a learning curve for all of us. And so we think we're ready, we hope we're ready, but we do want to make sure we're prepared for the unknown level. And I think you're going to do great out there. And if there's anything that we at the TrueCode team can do to assist you in getting ready, please let us know. We want to be a part of your team, we want to help you, and we would love to have you part of our family as well. I'm sorry I ran out of time as I usually do. I always have so much I want to tell you. We don't have time for questions today, but we will be saving those questions if you've asked them during the presentation, and we will be getting back to you on try to get you an answer to those questions. So thanks so much for joining us today. Again, it has been our pleasure to be with you for the hour. Hope you have a wonderful rest of your day, and we hope to talk to you soon. Thanks, everyone. Bye now.